We're ready to get on to our next kind of all teach, all learn. And so if I could have our two speakers up for innovation best practices, focusing on members. Thank you. We will, for this part of the talk, we'll actually introduce our first speaker and then do a quick Q&A because she actually has to get on a plane and leave, from what I've been told. So we'll let her do her part, and then we'll move on to our next speaker. So we have Sharon Chintraja, who's here with us. She's a clinical associate professor and is a researcher in food allergies and asthma at Stanford. And so we're delighted to hear your story.
Thank you. Thank you so much. It's such a true pleasure to be here and be inspired by all of the talks from this morning and Bruce's story. As a clinician, these types of stories are what drive the research and innovation within our center, is hearing about how medicine affects the actual individual and what we can do to improve the lives of our patients. So I'm going to tell you a little bit about our center, where we run clinical studies in food allergy and asthma at Stanford at the Sean Parker Center. A little bit about food allergies. Food is so much of our socialization with each other. Food allergies are a growing pandemic. It affects 6 million children under the age of 18 in the United States. That's 2 kids in every classroom. Growing up, I didn't know anybody with food allergies, and now I have 2 children who don't have food allergies, but are in classrooms where there are so many precautions for classmates who have food allergies. It also affects adults. A lot more of our adult population are developing food allergies to foods that they used to eat, and it's on the rise. It's more than just peanuts. There's 8 top foods in the United States. It's a little bit different in Europe and other countries, but it is now a problem in developing countries as well. It's not just a phenomenon in developed nations. 30 to 40% of patients are allergic to more than one food. We think it's more than genetics and environments. There's practices of how we introduce food into the diets of our children that we've learned from in the last decade. That early introduction of these top 8 foods is really important. How do we change that message and into the hands of the pediatricians who see kids early on in the first year of life to really prevent food allergy? But that's not all of the story. Many parents of children with food allergies never had food allergies or allergies themselves, so they're puzzled as to why their children may have food allergies. There's a lot of therapies now in development. And this is being driven by great mechanistic insights. So our center not only has a clinical research unit where we run clinical studies in food allergy and asthma, but we also have a lab. So we're trying to understand which immune cells are the key drivers involved in allergy. How do we intervene? And as I mentioned, prevention is really an opportunity, but not the whole story. Our current therapy for food allergic patients is avoidance. We had really great snacks outside. Some of them involve tree nuts, peanuts, many common allergens, right? It's very hard to avoid the food. And so what we see is that accidental ingestions are very common. This drives people to the emergency room. The rates of visits to the emergency room for food allergy are growing. Top causes are peanuts, tree nuts, milk, egg. These are all the top 8 allergens in the United States. The only therapy, is carrying reaction medications, which involve injecting yourself with epinephrine. So imagine a 6-year-old being told you just ate something that you're allergic to, and go ahead and just, put this needle in your thigh to help prevent a life-threatening allergic reaction. It's very hard for a 6-year-old to do that, even for the parents to do that. So this is the only therapy that's currently FDA approved for food allergic individuals. What our center and others around the country and around the world are trying to do are really change the landscape of therapeutic options out there for food allergic individuals. I want to tell you a little bit about that, and then talk about where we're really trying to expand our innovation digitally. We are trying to feed people with food allergies with the food that they're allergic to. And how we do that is we start out really slow with really dust, peanut dust, or egg dust, and build up slowly to increasing amounts over time. We have our own facility that manufactures food flours. In the eyes of the FDA, this is all research, and food flours, peanut powder, which you can buy in Safeway or on Amazon to, put a little protein into your smoothie in the morning, is considered a drug in the eyes of the FDA when we do this, because we're trying to change the biology, the immune system response to peanut powder. And we do that by just increasing the dose over time. It requires careful observation. You have to eat it every day to maintain safety and compliance, and really to maintain that immune response. And we've been able to build people up to a serving size of whatever they're allergic to a handful of peanuts, a glass of milk, and that has been life-changing. It's wonderful to be able to hear the stories of parents who now come back and say, it's a struggle to eat this dose every day, but it's opened our world socially so much more. Companies are interested in developing therapeutic grade peanut flour or other allergens. A recent phase 3 was published in the New England Journal. We were part of this. And what I want to show you here is really that within a span of 6 months to a year, we took people who were allergic to 1/10 of a peanut and took them to a point where 50% of them could tolerate 3 peanuts, which is really amazing. However, as with all of these therapies, right, there are side effects. The most common side effect is GI side effects. This makes it hard to eat peanuts every day if you're going to have a tummy ache or want to feel like vomiting after eating your dose. And so these are the barriers to implementing this on a greater scale. And the reason that this is so important is really people, parents of children with food allergies aren't wanting their child to be able to eat a peanut butter and jelly sandwich. They're trying to, go to a birthday party and not worry that they're going to have a piece of cake and end up in the emergency room. So this is why it's important, and this is where we've listened to our patients who've really driven this innovation in the field, because the patients have formed organizations and found funding to fund therapies for food allergy, because it's important them to be protected from accidental ingestion. This has garnered great support from the NIH as well for food allergy resources and grant funding. What are the barriers now that there are companies out there who are developing products to be able to treat people with food allergies? There's 2 companies that have done phase 3 studies, so the landscape will be changing in the next decade. This is an amazing field that with exponential growth. And safety and side effects are really important to overcome. Anxiety and compliance and duration of therapy. So far, we're telling all of our patients that they need to continue to eat this on a regular basis to be safe from an accidental ingestion. So the next generation of food allergy therapy, here we're just coming to a point where we can treat an individual with maybe some FDA-approved therapies that treat just peanut allergy. But as I mentioned, 30 to 40% of people are allergic to multiple foods. They also have asthma, allergic rhinitis, eczema. They're just allergic individuals. So this is a beautiful schematic that Emily Clark drew for us, where it's showing really the individual and how allergies affect all aspects, right? We've got antibodies, which drive the allergic reaction. We've got immune cell players there. We've got peanuts, tree nuts, respiratory allergens affecting the lungs. And that's what we're trying to do, is not just treat one allergy, but treat allergy in general. And that's really great because there's the biology in the field, all these other drug companies out there targeting specific cells and specific chemicals that are released from cells in the field of asthma, in the field of eczema, that we're trying to draw on within food allergy to treat all allergic responses. So that's our next generation, and this is results from our one study where we're treating multiple allergens simultaneously with the use of biologics. So taking it to the next step, and where we have been able to treat individuals for multiple foods with the use of biologics used in asthma, and then they're able to eat 2 to 3 foods, 2,000 grams serving sizes of milk, peanut, and cashews within 6 months, which is improving the safety, improving the speed, and perhaps improving the compliance because it's lessening the side effects, which is so important for continued therapy. Our next step is really to use digital medicine technology to help our patients. So what does that look like? That might be mobile apps that we're looking for partners to try and develop where we aid in compliance. So they have to log their symptoms on a daily basis. There's a lot of anxiety associated with it. Can we put some mindfulness into that application so that we can reduce anxiety, improve compliance? How do we train new generations of allergists out there who've never done food allergy? Looking at, computer simulations to be able to show how to treat anaphylaxis, how to treat allergic reactions. And then how do we improve our outreach? Right now our center is accessed by people who have the ability to come during working hours in the Bay Area and combat, traffic and all, to be able to be seen in a research center. What about people who have less access to allergy care? And that's where we're hoping to use, telemedicine to improve our access. And with that, I want to just thank my team and our funders. Funding is always an issue in research and in innovation. And thank you guys for your attention. And I'd love to talk to anybody who has ideas of how we can do this together.
Do we have any questions? Sure.
So I'm interested, personal standpoint, you're looking at food allergies. How are you thinking of like autoimmune disease like celiac and I would love to be able to eat bread again. So.
I know. And when I talk about food allergies in general, we're talking about IgE-mediated reactions and anaphylaxis, and celiac disease is a different biological pathway, and there are researchers who are looking at different immune mechanisms, how we can alter the immune system to be able to tolerate wheat. But it's under the umbrella of allergies, but without the IgE reaction. Oftentimes people with celiac disease don't have the anaphylaxis reaction, but they have the whole system. And there are other food allergies and intolerances that we need to address as well. I'm hopeful as we expand our digital footprint, these are factors that we can gather more information. Really, it's about trying to understand. We talked about specimens and different time points along somebody's journey, an individual's journey, right? Then that generate tons of data that we then trying to mine to understand how we treat the individual. And that's part of our center's goal. And so we see patients with food allergies, without food allergies, to understand how is this disease system different in this individual with allergies versus without, and how do we understand targets for the broad spectrum of individuals.
There's another question.
Hi, Leah from Chalk Children's Hospital. I just had a question regarding the initiation of the program. How long were they initially in the hospital? And did the insurance companies, was that funded, or did the insurance companies give pushback on them being in there for the desensitization process?
This is a great question. So this is all research, and insurance is not involved. Our research is free for our participants and volunteers who dedicate their time. But this is actually part of the issue that is getting sorted out as these companies move these therapeutics into the lay community. There's a board called ICER which evaluates drug therapeutic options and looks at the payer risk benefit ratio for how are we going to, is this a disease burden that's worth funding? What does the therapeutic cost? Is it going to be effective for insurance companies to be able to cover this? There are some workarounds that private practices have tried to implement to be able to offer this. Our research is already all done in an inpatient observational unit because of the risk of anaphylaxis, because we're really concerned about safety, and this is, first to really developing the concept. And so it's just day observations while they're doing it, and then they go home and they take that observed dose that we know that they tolerated safely in the clinic, and then can do it at home. They have access to us 24/7. Some of that is, clinicians like myself on the phone, fielding a phone call at 9 p.m. saying, okay, I'm having an allergic reaction. What should I do? I say, go to the emergency room, use your epinephrine. And they're like, oh, I'm scared. And I say, okay, well, let's FaceTime. We'll do this together. And we'll use the epinephrine auto-injector and make sure that you are well cared for, and we terminate this allergic reaction, because early use is really preventative of the larger cascade of the immune response.
Thank you so much, Sharon. Our next member who's going to share some best practices is Juan Espinoza. He is an assistant professor of clinical pediatrics at UCLA Children's and Keck School of Medicine at USC. And his research is in how digital media can affect medicine and medical education. But he'll be discussing health equity, which is an incredibly important topic for all children. Juan?
Thank you so much. Good morning, everyone. Thank you for having me here. It's really an honor to be in this room with so many peers who are doing incredible work in the country. I'm going to be talking about health equity and innovation. The reason that I wanted to talk about this is that I think that it's something that all of us are doing a little bit of in all of our clinical and innovation and research activities, but I think it's an important topic to be intentional and deliberate about. When I first heard Dr. Bhargava's talk at the beginning, the keynote, I was both excited that she was talking about some of these issues and then terrified that I didn't have anything else to add. So what I'm going to try to do is talk about more of a conceptual framework around health equity and innovation. So first of all, what is health equity? Many of you have seen diagrams or illustrations like this one. And what is the difference between equality and equity? Equality is where we support all people the same. Equity is the concept that some people need more help than others so that they can achieve the same opportunity. You may have even seen a variation like this, where we add the concept of justice to it, where we have now removed the systemic barriers that make it so that we need to have interventions that address health equity. So why does this matter to us? Well, we are pediatricians. We are the community of pediatric care, and the American Academy of Pediatrics has a very nice definition about what is a pediatrician, what does a pediatrician do? I think that we can abstract that to what does our pediatric community do? What do we do together to take care of children? And we, as pediatric healthcare providers, members of this community, we address the physical, mental, and social health of children. We look at a broad spectrum of health services ranging from preventative health care to the diagnosis and treatment of diseases. We are concerned with the biological, social, and environmental influences on children. We support efforts to create nurturing environments. And finally, we participate at the community level to prevent and solve problems. Hopefully this resonates with what you do every day at work at your institutions. And the reason we do these things, why we care about the social and environmental impact, is because we know that social determinants of health are crucial in determining health outcomes for our patients, right? Individuals are in a socio-ecological model of health where they are part of communities, environments, societies, and there's impact on them at multiple levels. And we know that as much as we like to think that the medical side is important, it really only accounts for about 20% of the health outcomes. Everything else determines the rest. So what is the role of innovation in this space? So I like to think of innovation as two possible fields. So one is medicine, and the other one is health. So when I say medicine, what I mean is the therapeutics, the procedures, the medical devices, the diagnostics, and the basic understanding of human biology that help us fight off death and human suffering. This is crucial. This is how we change the game. But this also takes a lot of resources, a lot of time, a lot of money. The other side, what I will call health, is everything else. These are the mechanisms by which we take medicine to people to make them better. Now, the good news is that the answer to what we do is actually relatively easy. We've known the answers for decades, centuries. Paul Farmer from Partners in Health describes them as people need 4 things. Oh, I'm sorry. So the role of technology is really to have this potential to narrow those health gaps faced by underserved populations. This is something that the Children's Health Fund has been advocating for years. But they also warn, and I think it bears reading completely, that if not developed and implemented equitably, technology advancements could actually widen disparities in care, as the haves get more and the have-nots are increasingly left behind. And so this is something that we have to think about every time we develop a system that maybe doesn't integrate with a Medicaid payer model, or that requires a certain level of resources on behalf of the patient. Now we can talk about what Paul Farmer says, which is we know the answers. We know what to do, right? People need stuff, we need staff, we need space, and we need systems. The innovation comes in how we deliver these things. So I'd like to propose that the role of innovation is to replace, complement, amplify, and optimize these tools that enable people to achieve their best health. So that might be decreasing the need for stuff, or multiplying the effectiveness of a small staff, or creating virtual spaces, or optimizing systems with data and feedback. The reason this matters to me and to my institution at Children's Hospital Los Angeles is this number, 72.6%. This is our percent of Medicaid patients at Children's Hospital. We have the single largest Medicaid population of any standalone children's hospital in the United States. And we are very proud of that. We're very proud of the fact that we are the only top 10 children's hospital that is also a safety net hospital. And so we take care of some of the sickest children in some of the most impoverished conditions and deliver some of the best care in the country. And that's something that matters to us. And so when we think about what is the innovation that we need to build, we think about that space all the time. So we've been lucky to build an innovation team that thinks about health equity, health justice, and social determinants of health in all of our activities. We are a relatively young team. Our innovation studio started 2 years ago. Omkar Kulkarni, our Chief Innovation Officer, joined in 2018. But we've built a really wonderful, diverse team. We have some members of our team that are hospital funded, some that are grant funded, both from our digital and international health work, as well as through our FDA medical device development work. And this is what allows us to try to address some of these issues, is this investment in thinking about the future and thinking about how we do what we do better. I do want to take a little bit of a moment to just talk a little bit about CTIP, which is the West Coast Consortium for Technology and Innovation in Pediatrics, which is our FDA-funded pediatric device consortium. The reason being that within all of innovation, there's this very tiny subset, which is pediatric medical device innovation, which may be the single hardest market to work in. There are regulatory barriers, or economic barriers, or philosophical, ethical, scientific barriers. And so the FDA created this program in 2007, first funded it in 2009, to really empower academic centers to identify promising technologies and support them. So our program is part of the 2018 cohort, so we're one of 5 centers in the country, along with Texas Children's, UCSF Stanford, National Children's, and the Pennsylvania Consortium at CHOP. And we're really tasked with identifying these early stage innovations and supporting those technologies to get them to market so that more children can take advantage of medical devices that were intended for them, not just adult devices that have been adapted, sometimes without specific testing, for pediatric use. So I hope that this has been helpful for you as you think about your programs, your projects, is that intentionality about thinking about what is the role of health equity in your approach to the problems that you decide to solve, to the technologies you decide to implement. Every problem is important, but using this lens of health equity in your innovation is hopefully something that will help achieve a moral good, which I know is a weird word to use in technology. We often don't talk about things like morality in the tech or science world, but I think it's important. So this is what I want to leave you with, that innovation is an approach, a set of tools, a way of thinking to achieve a moral good, that every child has a fair opportunity to be as healthy as possible. Thank you for your time.
Thank you so much for framing what we do within the concept of health equity, because again, it's really about